let's go through some examples here. Just like the previous section, the HPIs, I'll use kind of one made-up case and then go through some real-life assessment plans that I've taken as well and remove some of the details. So let's get started. So I'll kind of go through this and then kind of break it down later. This is an example that I was kind of referring back to is how people kind of write the assessment, the initial explanation, and just add a line on every day. So let's look at this one. So patient presented with dyspnea on exertion, orthopnea, P&D with JVD, elevated B&P with rails on exam, admit and give 40 milligrams IV Lasix, BID, consult cardiology, monitor strict ins and outs, monitor creatinine and electrolytes while diuresing. Her last echo was February 2020, which showed an ejection fraction of 40%. We'll update this as it's been greater than 1 year, currently on 4 liters nasal cannula, and will wean as tolerated, echo ordered. So this is a progress note, so this would be the next day, and so we have increased Lasix to 60 milligrams IV BID, appreciate cardiology on 3 liters nasal cannula, wean as tolerated, echo shows EF of 25%. So let's pick this apart here. So first of all, we're saying that patient presented with dyspnea on exertion, orthopnea, P&D with JVD, elevated B&P and rails on exam. This is just kind of a repeat of the history and the physical. I wouldn't really call that an explanation or clinical reasoning. I understand what you're getting at, but this looks more just kind of a retelling of everything more than anything else. So admit and give 40 milligrams IV Lasix BID. So we have now in this note, look at the inaccuracies. We have 40 milligrams IV Lasix here, and then we have Lasix 60 milligrams IV Lasix here. So we have it twice. We have consult cardiology twice, or consult cardiology here and appreciate cardiology. Is that really necessary? And then we have, let's see, an echo with an EF, both here and here. So we have two different EFs. Which one is accurate? We have one oxygen requirement here, and we have another oxygen requirement here. Which one is accurate? We have will wean as tolerated twice. Is that really necessary? Look at all that duplicated information, inaccurate information. Look how much that looks that you're going to have to edit it every day. And what the heck is our assessment? Is our assessment just CHF? Is it chronic CHF? Is it an exacerbation of CHF? I don't know. So this is a very classic example of what I see very often. So how would I improve this? So first of all, we have an EF of 40% initially, and later on EF of 25%. So I'm going to call it a heart failure with reduced ejection fraction exacerbation. So again, I wouldn't really call this a reasoning. So I don't know, maybe the ER, I hate to keep picking on the ER, but maybe the ER called this patient a COPD exacerbation. And maybe I disagree with that. So I'm going to say I suspect the wheezing is a cardiac wheeze and presentation consistent with heart failure exacerbation due to the elevated JVD, BNP, chest X-ray with pulmonary edema, etc., etc. The old EF, I think I have a different EF, but whatever. The old EF, I just have the date here, July 2020, EF of 30%. And then this is my initial plan. So I actually have, this is going to be my initial plan, and this is going to be my progress note here. So this is our old EF. Start Lasix, 40 milligrams IV Lasix BID, obtain an echo, consult cardiology, continue home Entresto, Toprol, and Aldactone on 4 liters nasal cannula. Now, the next day, and I guess I'll just bold this because that's our assessment and diagnosis here. So the next day, now we've obtained the TEE, so that is gone from this part of the plan, and I've just updated the echo here, and I've deleted the old one. So, I've just, February 20th, 2023, EF 25%. I have removed my reasoning because it does seem that this whole presentation is consistent with heart failure, so there's no need for me to continue to rehash that every day. So I have net negative 500 cc's over 24 hours, remains on 3 liters nasal cannula, and so increased the Lasix to 80 milligrams IV Lasix due to inadequate response to diuretics. So, and then continue home Entresto, Toprol, and Aldactone. So I'm including the net negative every day to kind of help me keep track, especially again if you have multiple heart failure patients. Sometimes you can lose track of all these. This helps me keep track and also relays maybe why we're increasing the Lasix. Remains on 3 liters nasal cannula. And again, this is all much easier to read. I don't have duplicated information like this person did up here. And also I am going to keep, I'm not going to move just these medications. So this is kind of our evergreen portion, right? Because this is not going to be, this is nothing changed from day to day. This is our evergreen portion. And I have this highlighted here because I want to remind myself to say this is not a copy and pasted echo report. My goodness, I see that so often that people just copy and paste the entire echo report. You're a doctor, pull out the important information, the echo, and how it's going to affect your management. Put it there. And then if somebody really wants to look at all the details of the echo, they will go to the echo report themselves. So I'm going to say continue home Entresto, Toprol, and Aldactone here. And I'm not going to move that into the evergreen portion here because I want to continue to monitor every day their electrolytes, their blood pressure, the creatinine. So I want to continue to remind myself whether or not I should continue these medications or not. And so I just kind of added down here, this is, say, my other problem, primary hypertension. I have Entresto, Toprol, Aldactone as above under heart failure. So if I end up holding one of these medications or reducing the dose or whatever, I'm going to do it here, and then this is always true. I don't have to update it multiple times if I'm not going to have two different statements in the same note. I know some people will argue to just not even state the net negative 500 cc's in 24 hours or remains on 3 liters nasal cannula, just put, on oxygen, wean as tolerated, or just not even include this. In my opinion, this is sacrificing specificity and accuracy all for the sake of kind of making things evergreen. So it'll be accurate, but it's not going to be help kind of convey the patient's clinical picture. So hopefully that helps make a little bit more sense about this. And so let's move on to the next case. So let's go through two more cases here. Both of them are consultant notes. The first one that we have here, if memory serves me correctly, I believe this is a cardiologist assessment and plan. As I recall it, the patient came in with a heart failure exacerbation. I think there was, then we maybe over-diuresed and then had some elevated creatinine, so we switched to PO Lasix. So that's just kind of some background stuff there. So let's look at the notes, see how we may be able to simplify it here. So first of all, we have lower extremity edema, which again is not a diagnosis. Maybe that was an initial problem that they came in with. I'm not 100% sure. Then pulmonary hypertension. So is that the main problem that we're treating and is going on? Known history of PAD. So we have a history of, and it's a completely different, separate chronic comorbidity here. So I would just move this to, so I kind of have what I have here. So I would just move PAD, just going to whole another problem list here. Pro-BNP within normal limits. So I believe we had, we were diuresing, then we switched to BNP, looked normal, so we switched to PO Lasix. So we've been continuing PO Lasix. We've been on PO Lasix for a few days now, so I would probably just remove this by now. Strictins and outs and daily weights. Like I mentioned this previously, I would just move this to just kind of the evergreen spot if you want to include it. So the next line, we have a net negative disadmission, not all urine output captured. Again, I kind of mentioned that's kind of similar to my old note. I would just move that now. We're going to be, is that something we're going to be monitoring every day to keep track? I would put that into a bullet point and just put net negative 18 pounds and negative 5.1 liters this admission. And that's what she has here, the admit weight and the current weight. So on PO Lasix, 1, I'm not sure what the 1 means, so I'm assuming they mean continue PO Lasix. They're the cardiologist, so I'm going to change that to continue PO Lasix. And they have a note here, acute on CKD. So look, I like the acute on CKD. I maybe have that as a second problem, like I have down here, acute on CKD, chronic CKD, improving. And so I would just maybe put continue PO Lasix as creatinine is improving. That's how I would kind of summarize that. Echo with low normal systolic function, indeterminate diastolic dysfunction. So we don't have an EF here. I just kind of made one up here. They said low normal, so maybe it's mildly reduced. So I'm gonna call it EF of 45%. And I just put the echo date here. There's let's see, she has 8/19, so I just put 8/19. The echo date here. The pulmonary artery pressure I just moved. So I kind of moved the pulmonary. I kind of moved the pulmonary hypertension here, just kind of down here, and then put the pulmonary artery systolic pressure down here with the date of the echo here as well. So this is kind of their plan. We're finally kind of getting to the plan. We'll sign off, follow up with Dr. Smith in 3 to 4 weeks. So this is how I would structure my note if I was a primary team, but as I mentioned before, this is actually a consultant. So this is what I would do as a consultant, because remember, you are a consultant to the primary team. So this is what I would recommend doing so that your plan is clearly delineated, especially if you're at a hospital system where the primary team is expected to put in all the orders. This is what I would do, something like this. So the primary team, if they just want to know what you recommend, they can look at your note and just jump to, okay, plan, continue PO-LASIK, signing off, follow up Dr. Smith. Okay, got it, which is much quicker to see than all of this stuff. Okay, this is our second example here. You can already see just that looking at this. This is a lot to read. This is a lot to update every day. And as a primary team looking at this is very overwhelming. So let's see how we can simplify this. So let's just go through it line by line. So acute kidney injury on CKD stage 4. I like that. As a CDI director, I like that. So I'm going to keep that down here, AKI on CKD stage 4. Long-standing history of diabetes, uncontrolled, and hypertension. So it looks like they're explaining the kind of underlying etiology of CKD here. I don't know if that's terribly important on in an acute hospitalization, but I understand that maybe this nephrologist has a lot of different CKD patients, so maybe they're trying to keep it straight in their head and using their note to do that. I understand that, so I'm gonna keep that here. So I'll say CKD, likely due to uncontrolled diabetes and hypertension. There's some mention here. Let's see, known CKD, followed by Dr. Smith with a baseline creatinine fluctuating due to heart failure. So okay. So again, maybe, so from a CDI perspective, I prefer to have an actual documented baseline creatinine. And FYI, I'm not going to get into too much detail, but you should use just one number for the baseline creatinine, not a range. So but anyway, I'm not going to get into that. But so let's just use what she said. They said here. So fluctuating baseline due to CHF and diuretics. So this is kind of our underlying evergreen stuff. This kind of explains the underlying CKD. So I'll keep that there. So per review of records, she appeared over waiting to no peripheral edema. Her diuretic regimen was decreased. So we kind of have a history here. I don't know. And this is FYI, this is days and days and days into a hospitalization. So I don't know if including this every single day is important. Initially hypotensive, pressure 90s over 40s documented initially, possibly ATN. So I like that. So this should be up here because this is now part of our diagnosis. So I moved this up there. So I said I put due to presumed ATN. And again, as a CDI medical director, it is totally okay to include presumptive diagnosis in the inpatient setting. Where are we? So I kind of moved this here. I'm going to get to this later, but I kind of have ATN likely due to initial hypotension. So again, I understand. So they have, presented with a creatinine 3.1, continues to rise to 4.4. So again, this is loss. I'm impressed if they are updating this every day because this is very just lost in the mix here. So I'm going to move this. This is going to be a first bullet point. Creatinine 4.4 today compared to 3.1 in admit. So now I know every day. I'm just going to, first line right here, I'm going to update the creatinine every day to see how. So it's not going to get lost in the mix here. UA reviewed. Again, this was probably days and days and days ago as we're several days in the hospitalization. But again, I understand maybe they have a lot of AKI and CKD patients in the hospital, so they're trying to keep track of it. So I'm okay with that. We'll keep that again in the evergreen portion of trying to keep up, like I was mentioning previously with the encephalopathy example, trying to keep up with what was positive, what was negative, what is pending. So we're going to move that to our evergreen portion here. This is the UA, and then your EO is negative. I've moved this here as well to our evergreen portion. Some quantified proteinuria here, so I've moved that as well here, and holding RAS. So I'm now going to move that. So now they're continuing to recommend holding our RAS inhibitor. So I'm going to move this down here. I'm going to add the I there. Continue to hold the RAS inhibitors in the setting of AKI. So yeah, due to AKI. Renal imaging review, no hydronephrosis. Again, this is all old stuff because I know. So renal ultrasound without hydronephrosis. Again, I had this kind of in our evergreen portion there to keep things straight. They have mentioned this kind of heart failure stuff. I don't know, maybe were they thinking cardiorenal syndrome? I'm not sure. Again, I don't have an explanation there, so I'm not quite sure why they're including that. I would maybe just remove that since it's not clear. Chronically maintained on 2 liters nasal cannula at home. Now, I would just move that to a whole different section, maybe some chronic respiratory failure with hypoxia section. Maybe they're making the point because this patient has rising creatinine, so they're talking about indications for dialysis. So maybe I will move that to maybe we'll say no indications for dialysis today because patients on home 2 liters nasal cannula. That way there's a little bit more context of why are you including this in an AKI on CKD note. Status post Lasix administration on February 16th, and then another dose on February 17th. Lasix 100 milligrams, no significant response to diuresis, peripheral edema improved. So I'm going to move that just to another plan. So now they're not recommending any further diuretics. So I'm going to say hold on further Lasix as status post 100 milligrams IV Lasix on February 17th with minimal response in the urine output here that they included. Here we go. Urine output here. Maintain Foley for strict in and out. So I'm going to say continue Foley here. That's again part of the plan. Hemoglobin low, status post 1 unit. Not sure why they're including this under AKI. I would probably I would move that to maybe an anemia section. I would get rid of that. No sign of improvement in renal functions. We've already talked about that, so that's just kind of a repeat. She reports feeling dizzy while working with PT and OT. Follow-up orthostatics. Addendum orthostatic BB readings not indicative of orthostasis. So I don't know if they went back to addend their note later or this is a following day. I'm not sure, but I'm just going to shorten that to obtain orthostatics to evaluate for dehydration. And patient without indication of acidosis or hyperkalemia will continue to monitor for need for renal replacement therapy, continue to hold Plavix and aspirin. So again, we kind of talked about that up here, no indications for renal replacement therapy, and then continue to hold Plavix, aspirin and Plavix. And now what I'm inferring here is that they may continue to hold it in case of need for dialysis catheter. So again, I don't want that buried in an assessment and plan. If I'm recommending that to the primary team, I want to make sure that's not buried. So again, I want that a little bit better to be more visible here. She is amenable to renal replacement therapy. So so we've come from this to this, which is shorter. Again, we have the diagnosis here, AKI on CKD stage 4 due to presumed ATN. We have the reason for the CKD, again, to keep things straight for the nephrologist. There may be the reasons for the AKI, what's been negative or positive. Again, for the nephrologist with all their AKI and CKD patients. We have our creatinine, which we reviewed. That's important for medical decision making as well as kind of conveying what's going on with the patient. Why are they still here in the hospital? And then their direct recommendations are recommending a Foley, obtain some orthostatics, and continuing to hold these medications. I think this is a much easier to view as a primary team. And then later on the next days, this is way easier for them to edit. So hopefully that kind of drives home the point and make things make a little bit more sense for you. So I am coming back after recording that initial video because I was reviewing the video and I said, oh boy, I have today listed twice in the first line of this assessment and plan. Everybody's going to come back and fuss at me because I'm breaking my own rules. But I'll say this, first of all, whenever you edit your note like this, it's much easier to edit, so you're less likely to copy forward some of these accidental todays, yesterdays, stuff like that. And point number 2 is that, in this situation, we were watching the creatinine every day because every day it was, oh, does this person need dialysis today? Does this person need dialysis today? So that is a situation where I know every day I'm going to be updating the creatinine and do they need dialysis today or not? So, there's a caveat to every rule. So just kind of nothing is black and white, nothing set in stone. So just, but hopefully that helps explain that so nobody gets too angry at me.